Hello, everybody. I hope you can all hear me very well. So, I'd like to welcome you all to the launch of our surgical lecture series. The Association of Women Surgeons AUB chapter was recently founded in the beginning of 2020 by a group of graduating medical students who are the class of 2021 at the American University of Beirut. This was actually the first established chapter in the region, and this is our first event, so we're very glad to provide you with a very wide variety of talks and lectures given by multiple different surgeons and residents. We really hope you can benefit from these talks, whether formal or informal, series of lectures, and they will be spanning over the coming 2 months. So we hope this is an experience that you'll really enjoy and benefit from. So I'd like to take a moment to introduce initially the Association of Women Surgeons AUB chapter core team, a big portion of which was involved in organizing this particular event. I'd like to introduce first and foremost Ms. Christina Abifaraj, Med 4 as president, Julie Samouri, Med 4 as vice president, myself, Rasha Kakati, Med 4 as logistics coordinator, along with Nahla Dayer, who's also a Med 4. Joel Alam, who is Med 4 and acting as a secretary. Suha Farhat, Med 4 as social media coordinator. Raya Tuma Sawaya, Med 4 member at large. Joel Busaba, Med 4 as PR coordinator. Asim Nahran, Med 4 as treasurer. Joel Shami, Med 2 as previous Med 1 representative. Diane Ghanem, Med 3 as previous M2 representative. And Francesca Kahalim, MD, who is the previous M4 representative. So initially, I'd like to leave the floor to Ms. Christina Abifaraj, who would like to say a word. Christina?
Yes, thank you, Rasha. Hello, everyone. This is Christina here. Welcome to the AUB Surgical Lecture Series. So, when we initially started our Women in Surgery initiative, it was intended to spread surgical knowledge, inspiration, and motivation to young students such as yourselves to go ahead and reach their dreams of becoming surgeons. And today, I'm very delighted to see this initiative fulfill its mission. As you all know, and during these difficult times the world has been going through, the medical students' exposure to clinical and surgical cases and their away rotations have been largely affected. So, I really hope that you make the best out of this lecture series and that you benefit as much as you can from it. And on this occasion, I would like to thank all our speakers who are participating and giving these valuable lectures, the team who worked tirelessly to put this series together. And I know that the past couple of days were a whirlwind, where the team was actually trying to finalize all the schedules. And finally, the 400 plus students and interns registered who also happen to come from multiple countries, including Lebanon, Jordan, the United Arab Emirates, Palestine, Syria, Saudi Arabia, Qatar, Bahrain, Cyprus, Poland, Czech Republic, Hungary, Guatemala, Indonesia, and India. Thank you all again, and I hope you enjoy this series. Rasha, the floor is yours.
Thank you, Christina. So, first of all, I'm very glad and very humbled to introduce our very first speaker, who is an exceptional surgeon and also an exceptional mentor and individual as a whole. Dr. Ramzi Alami has specialized in the US for over 14 years in bariatric and weight loss surgery. He is specialized in surgeries ranging from sleeve gastrectomies, gastric bypass surgeries, and gastric bypass. And he's been helping lots of patients with morbid comorbidities, including diabetes and metabolic syndrome. He also performs many different surgeries, including hernia repairs, cholecystectomies, and gastrointestinal tract interventions. He's also highly adept at minimally invasive and robotic surgery with extensive training. Dr. Alami is currently the head of the Metabolic and Bariatric Surgery Unit at AUBMC and is an associate professor of surgery. He's previously been the surgical clerkship director for medical students and the associate program director for the surgical residency program. Above all, Dr. Alami is well-rounded and holistic in his clinical approach. He's one of the few surgeons who plays the most amazing music in the OR from personal experience, and he makes sure that all his patients have really personal requests for the music that they're falling asleep listening to, and he builds a very strong rapport with them on a personal level. So we're honored to have Dr. Alami as our first speaker to give this unique and special talk during these recent times in Lebanon. Sometimes we can't overlook essential topics and events, even though they might not want to look back on. So the Beirut Port blast that took place on August 4th, different ways that we cannot often describe or put into words. We often discovered things about ourselves and about each other, and we learned more than we ever thought we could and saw things in a different light. Surgically, AUBMC handled a large portion of the casualties of the blast. And Dr. Alami was one of the first surgeons to rush to the emergency department when the blast took place, and he was essential to the strong and effective response of the entire surgical team. I'll leave the rest for Dr. Alami to go into, but before, if you have any questions that you'd like to pose, I'd like to request that you please type them in the chat box. We'll be leaving a 10 minutes Q&A at the end of the session where your questions will be relayed. So I would like to request that you kindly keep your microphones muted throughout the session. Dr. Alami?
Thank you, Rasha. Thank you, Christina, and all of the committee members for arranging this. It's a great honor to be the first speaker. I don't know if I should be happy about that or thank you for getting me into this, Rasha. I don't know. When Rasha first approached me about this lecture series, honestly, I thought it's a great idea. I was very excited about it. And obviously, she asked me to talk about something that's a bit more in my niche, things like bariatric surgery or abdominal wall reconstruction and so forth. Honestly, I told her what I'd like to do is maybe take advantage of the recent events to touch on what happened, more from a personal standpoint. So this is really going to be a very, very informal lecture. That I have no slides. What I'm going to try and get to you out of this talk or whatever conversation, if you want to call it that, is how I personally was prepped to deal with what we have to deal with through my training, through my experience, and so forth. And I think that maybe that might be a little bit more helpful than me going through ABCs and so forth of trauma. So as Rasha said, for this to make sense, let's keep the microphones muted, but I think we'll probably end up with a much longer Q&A. I do not necessarily want to hog this conversation. I think it's going to be a great two-way conversation or a multi-way conversation. Looks like we have quite a few participants. But like she said, let's type in questions and so forth. I will try to look at some of the questions while we go through and see if there's anything that needs to be answered immediately. Before we get into August 4th, I think what helped me get to through August 4th is basically my past. So I'll go through that a little bit. I graduated from AUB for both my bachelor and my MD, and then I went on to the US for my residency training. I started my training in Richmond, Virginia, at the Medical College of Virginia, which is now known as the Virginia Commonwealth University. My residency was in mid-residency. I was a third-year resident when September 11th happened, on September 11th, 2001, sorry. And being a third-year resident, I was typically the consult resident. And that day, I remember going to the hospital. I was also doing my endoscopy rotation. So I went to the hospital and was having my morning coffee. And then we started hearing all the news about planes crashing into the towers in New York and potentially a plane crashing into the Pentagon. At the time, my sister was a banker at Citibank on Wall Street. So immediately when I started hearing the news, I obviously was trying to get a hold of her. Cell phone lines were not working, landlines were down. It took several hours for me to be able to get a hold of her and know that she's okay and relay that message to Beirut. Richmond is about an hour drive from the Pentagon, which also was the victim of one of the planes. So there were a lot of casualties in Washington, D.C. and the Pentagon. So being as I was one of the few mid or senior level residents who was outside of the operating room, the chief of trauma at my hospital, Dr. Rao Vituri, called me up and says, we're expecting several of the victims from the Pentagon to be transferred over. We are the closest burn unit and the closest major ICU. So you need to start going around to the emergency and the ICUs and make sure that we're ready to receive those patients. So go around, get patients out of the ICU, clear beds, get things like the level 1 infusers that we have in the operating room and the ICUs, get them down to the trauma unit, to the burn unit, and so on. And that was really probably my first real experience with mass casualty, or getting ready for a mass casualty experience, getting ready for the victims of 9/11. Um, we were told that we were receiving at least 12 major burn victims. They were all coming by land, by ambulance. And so we had to prep for those. To give you an idea, our burn ICU could take 4 patients at a time. It was full. So I had to go around and start clearing out other ICU beds. Um, Unfortunately, none of those burn victims made it. They all died on the way. So we didn't really have to take care of them in the end. VCU was a big trauma center. It was a level 1 trauma center. And so gunshot wounds, stab wounds, car accidents, all of those were very commonplace, very common happenings, part of the daily routine. Mass shootings were not that common, but during my residency, we did have a sniper who was going around the Washington, D.C. and Richmond, Virginia area, just shooting people at random. So we were always sort of prepared for that. And every now and then you'd get a drive-by shooting where your emergency room was inundated with 7, 10 gunshot victims at the same time and so forth. I followed that up with a fellowship in minimally invasive and bariatric surgery, so not much to do with trauma there. But when I was doing my fellowship, the head of trauma at Stanford comes up to me, and his name was David Spain. He goes, "Ramzi, I need you to take some trauma call." And I'm like, "Dr. Spain, I'm not a trauma surgeon. I didn't do my fellowship." He goes, "You know what? You graduated from MCV. You can deal with trauma any day with your eyes closed. So you're taking trauma call as an attending." So all of a sudden, my trauma calls went from gunshot wounds and stab wounds and mass casualties to people falling off their horses in Palo Alto, or being kicked by a horse, or I don't know, being punched by a 12-year-old or something. Not real trauma. Needless to say, I gave up trauma when I moved to my attending position with Kaiser Permanente. And when I moved back here in 2012, trauma was probably the furthest thing from my mind. Luckily, there were quite a few trauma surgeons here, and I didn't need to take any of the brunt of it. But really, you cannot escape trauma here. And my first experience with trauma in Beirut was the explosion in downtown, the Shattah explosion, if you guys remember that, the one that happened close to Starco, which is also close to where I live. That afternoon, I was finishing up a sleeve gastrectomy. I went out to the front desk to get a pen, and all of a sudden, I start hearing that there's a huge explosion that happened in downtown and happened in this area, and I'm thinking, shit, that's right next to my house. Trying to call my wife, make sure everything's okay. Obviously, cell phone lines are not working, can't get through. Finally, I get a WhatsApp message to her and from her saying that she and my kid are fine, and the house is fine, we're okay. So that was one of my first experiences in Beirut with mass casualties. And what you quickly realize is that chaos has a different meaning in Beirut. It's on a different scale. Um, no matter how organized you are, the chaos will overtake everything. So we didn't have a huge number of casualties from that explosion. Definitely didn't have too many casualties that showed up at AUB. It was a fair number, and I can't remember the numbers to be fair. But what I can tell you was the emergency room was a complete zoo because of everyone who was coming to check on a loved one, or who was coming to make a political statement and so forth, and yada, yada, yada. And of course, that's when everyone realizes that we do need to have a plan in place. It's important to make sure that when we do have such an event, that things are not as chaotic as that, and that there's a plan and there's some sort of strategy to dealing with it. And so we did develop a disaster plan, um, how to deal with mass casualties, and we had a few drills. So we would every year we would hold 1 or 2 drills of how to deal with mass casualties, and everything would be very nice and organized and all of that. And we tried to make it that simulation as real as possible. with some good actors and so forth. So if anything, we thought we were well prepared for anything that can come our way. One of the first things you learn when you're dealing with trauma is, I think all of you are very familiar with the ABCs of the ATLS. But what one of my mentors told me once was, before you apply those to your patient, make sure you apply them to yourself. So take your own pulse, make sure you're breathing, take time to breathe and think and all of that. Get organized before you try and deal with your trauma patient. Because if you're all over the place, your treatment is going to be all over the place, and you're not going to be effective. So to be able to follow the ABCs of trauma, you need to apply them to yourself. And that's, I think, a very good lesson in life in general. Always sort of just take a minute to take a step back, take a breath, take control of your own pulse and your emotions to be able to face what's ahead of you. So 6 o'clock, 6:05 on Tuesday, August 4th, Resha was with us. We were having Journal Club. If you're familiar with AUB, you know SB 101. It's one of the conference halls in the sub-basement of the hospital. So we're sitting there being all intellectual and discussing different articles about different topics. When the ground starts shaking, the roof is rattling, you hear this first explosion. Initially we all just look at ourselves and we're like, what's going on? Again, take your pulse, look around. Nothing seems to be seriously damaged. We don't know what this is yet. And then all of a sudden, the second explosion happens, and that's when everyone realizes the shit's hit the fan. There's something seriously wrong. A major explosion has just rocked the building. One of the chief residents, who was also presenting, Taha, initially takes charge and starts directing people to the different exits. I direct people to the other exit. We all take the stairs and start heading up to the lobby of the hospital. It wasn't a women and children first sort of scenario, but was pretty orderly and organized. We take the stairs and I get into the lobby and it's all chaotic. I don't even know what floor of the hospital I am in. This is a hospital that I know inside out, and all of a sudden we get into the lobby and I'm like, where the hell are we? It's dark. Lights are flashing all over, the emergency lights and alarms. There's no electricity, obviously. There's dust all over. The ceiling has fallen. There's glass all over, and there's people screaming. We step outside. Initially, of course, all of us, I think, thought the same thing. Major explosion just hit the hospital for some reason. We step outside, look to the hospital, it's fine. I take a look towards downtown, and I see this huge pink plume of smoke, and one of my fears comes to realization. I think this is a major bomb that happened in downtown at Baker Wasat, opposite my home. It's a major. Luckily, I knew my wife and kids were not in Beirut, they were in the mountains, but I figured they're going to start worrying about me and the cell phones are going to go off in a few seconds. So I shoot a WhatsApp to my wife and to the family group, letting them know I'm okay, and then turn towards the emergency room. At this point, I've also got at least 10 of the surgical residents all standing out there with me. I'm thinking, what the fuck is happening? What do we do now? They're looking at me thinking, what the hell is happening? What do you want us to do now? And immediately, and is our disaster drills and our disaster plan. Our disaster plan says everyone converges on the surgical library on the 4th floor so that we get walkie-talkies and we start assigning people as needed to the emergency room so that people are in the right place where they are needed. So I look around, tell 2 of the residents to go straight to the emergency room. Rest of the residents, let's go to the surgical library. Like I said, the lobby was completely destroyed, so the way to the surgical library was through the emergency room. We didn't make it to the surgical library because patients were already in the emergency room from the explosion. So the chaos already happened. This was not one of those disaster drills or disaster scenarios where you get a call saying there's been a major explosion somewhere, expect patients in 10 minutes or 15 minutes, let's start getting ready. This was a scenario where there was just a huge explosion and patients are already in the emergency room because all of Beirut has been hit and rocked. So needless to say, none of us really made it to the surgical library. We immediately sort of got into the midst of the action in the emergency room. I think a lot of you were probably involved in one way or the other in your own hospitals and helping out. So I think we all realized what the chaos was like that day. And at some point, we all need to take into account what is going to be our role in this chaos. My role as an attending surgeon, I don't see my role as someone who should be suturing or stapling people's heads. That can be done by anyone. I need to make sure that I can identify patients who need emergency surgery, patients who are going to be critical, patients who are going to potentially die, or patients who are not salvageable. This is where, again, you have to disconnect and cannot disconnect because a lot of these patients are family, they're friends, they're people you might know, work with, and so forth. But you have to be able to make some really serious decisions. And so, if you don't mind, I'm just sort of going to go through how that night evolved for me, at least what I remember of it. And hopefully, I'll be able to pepper it with a few teaching points here and there. So first things first, you don't want to be dealing with trauma when you're wearing a suit and tie. I rushed, changed into my scrubs, got into comfortable shoes. Again, I'd already made sure that somehow my family would know that I'm okay, so I don't have to worry about that. But I did call my neighbor to ask him to check on my home, make sure that nothing happened to anyone around there, and got back to work. So first few patients who show up are not your most serious patients. Of course, every patient is in distress. They're scared. They're bleeding. They're panicking, and they're coming to you for help. And so they come in with minor injuries, but a lot of blood, and they expect to be treated as if it's a normal day. We cannot do that. We, in fact, especially at AUB, cannot be treating minor injuries during a scenario like that. We are going to be the ones who have to deal with the more serious injuries. So I felt that the first place I needed to be was at the door of the emergency room, helping out with the triage of patients, because really we didn't have a system yet. And so I spent quite a few minutes of the opening hour just standing at the door, directing people to go to other smaller hospitals around, Najjar, Khoury, CMC, to a certain extent, Trad, because their injuries were relatively minor and could be dealt with anywhere. And at the same time, if anyone looked like they had serious injury, made sure that they were getting the treatment that they needed. And then all of a sudden, cars and ambulances start arriving with the serious injuries. I think it's, if you think of the numbers and if you look at some of the numbers that we dealt with, our emergency room is equipped to deal with, I believe, somewhere around 42 or 46 patients at any one time. We know that we treated at least 600 patients that day. I can tell you we probably treated more, many of whom probably just quickly sutured or quickly treated and then went home. They weren't serious enough to be admitted, but we did end up admitting 67 multi-trauma injuries. And I took a screenshot of the OR schedule for that day. So I'm going to show you that. Start sharing my screen here. This is the OR schedule of August 4th. It wasn't a particularly busy day. In fact, people were being inefficient. You can see a lot of wasted time between cases and so forth. So it was just your typical day at AUB. People are being nice and inefficient, but the cases are going through. And then all of a sudden, after 6 p.m., you can see all the red is basically life-saving cases. And to give you an idea, craniectomy, craniectomy, exploratory laparotomy, craniectomy, mediastinoscopy, or sorry, chest basically, sternotomy. Not sure what this was, but a 4-month-old kid. That's right, fracture, I think. Finger amputations, craniectomy, 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 craniectomy. XLAP for liver and diaphragm, craniectomy, We did 14 craniectomies that day. We have 4 full-time neurosurgeons at the best of times. One of the neurosurgeons, his house was completely wiped out. He was at home. Luckily, he was unscathed and uninjured, but he couldn't make it to the hospital. There was one neurosurgeon who was present at the hospital, and already you can see he started operating on more than one patient. Another neurosurgeon was on his way here from home. And a fourth one basically had reached the mountains in Baghdad and was on his way back. When I called him, I saw that the emergency room was full of patients who had serious brain injuries and needed to go to the OR. And I knew that Dr. Darwish was already busy in the OR, so I called him and asked him where he was. He said he's stuck in traffic with Doda. Said, okay, can you make it any faster? We have at least 4 patients who need to go to the OR. He says he's doing the best he can. 20 minutes later, I call him again. He's still stuck at the same place. Says that the traffic is not moving and he's basically stuck in his car, not moving. I had my driver come pick up my husky on a motorcycle, so I call him up and say, Mohammed, instead of going to my house to check on it, please go pick up Dr. Ames from this point in Dauda and bring him to the hospital. So again, I wasn't behaving as a surgeon trying to suture people or anything, but I was trying to make sure that patients were getting what they needed. And what we needed most at that point was a neurosurgeon. And so Dr. Ames basically made it in time to meet two of the patients who were going at the OR at the time. So again, you don't want to be caught, sitting there doing something like suturing someone's leg wound or stapling their head when all this chaos is happening around you and you have a lot more to offer. So after we got enough people to take care of the triage, I started going from bed to bed in the emergency room, trying to make sure that everyone was getting the care they needed. And of course, you start running into people you know. So Violette's mother is pretty badly injured. Her 2 daughters had massive injuries to both of their legs. They didn't seem to have any facial trauma. Her mom had significant facial fractures. And when we scanned her, she had a bad subarachnoid hemorrhage. Nothing that needed surgery immediately, but she was pretty critical. We need to keep an eye on her. And of course, I can't just sit there and babysit her. So I kept a mental image of where she was in the emergency room, especially after seeing the subarachnoid hemorrhage on her CT scan. You bump into a lot of people who are lost and need just looking for a loved one or something. And that's easy enough. That's a sort of a low-hanging fruit. You feel really good that you helped someone and made them feel good while not wasting any time or losing sight of what you need to be doing. But one thing that I realized was in all of this chaos, we really didn't know what was going on with a lot of our patients. And I quickly realized this when I was basically in the main trauma bay. We had a patient who had a obvious bad brain injury, was being intubated, needed immediate CT scan so we could decide whether he was going to live long enough to be taken to the operating room, whether we should try taking him to the operating room, whether he needed to go to the operating room. And so he was definitely a priority to go into the CT scan. So I walk over to the CT scanner, and that's another rule, by the way. never really run. If you run, you trip people around you, you make everyone panic. So walk at a fast pace, but never really run in an emergency. So I walk over to the scanner and they're getting a patient off. There's a 4-day-old girl who needs to be scanned. She's there with her father and the nurse who's taking care of her. But she's moving, she's crying, she's not vomiting. There's no obvious trauma. There's no obvious deformities anywhere on her body. And so I had to look the father in the eye and say, she is not the priority to go into the CT scanner. Um, you can't imagine having to tell the father of a 4-day-old girl that their precious baby is not going to go into the scanner next in a situation like that, but that someone who has a major head trauma has a priority over her. So we get that patient into the scanner, and one of our radiologists was on board. He was reading the results of the scan as they came out. So immediately as the images were coming out, he was reading them. But I look around and no one's recording what he's saying. So he's reading CT scans, he's telling people what is wrong with these patients, but no one's actually writing it down. And that information is just going into thin air all of a sudden. So we find some random papers around in the CT scan office, find a big felt pen and just grab one of the medical students and tell him, you're right now the transcriptionist. You have to record everything that forgot his name now, but everything that the radiologist is saying in very clear, big handwriting, and you stick it on the patient when they go out, so that you don't have to have the inefficiency of people coming back in and saying, hey, you know that scan on that patient with a head trauma? Well, everyone came in with a head trauma. Which one? So what are you looking for? And again, this is all part of taking your own pulse, right? You make sure that in the chaos, you try to instill a little bit of sanity or a little bit of order. Obviously, more people came to organize, and things, although we were getting more injuries, things were getting much better organized. So then you start realizing that your role as an organizer is not as important. Now your role is to go back to being a surgeon and make sure that every patient who may be a catastrophe we didn't see them as a catastrophe initially, but we need to start taking a look again and make sure that we didn't miss any injuries. So here I am, I'm taking a little breath and my phone rings and one of my friends says, my wife was injured. She's outside the emergency room, but they're not letting her in. Can you tell me what's going on? So I step out of the emergency room looking for her. And right as I step out of the emergency room doors, a lady comes up to me and she's like, you're Ramzi Alami. I have Nabil Makari's son. He's in the car and he's injured. Nabil Makari is one of my close friends. His son, Mac, is 10 years old. So I run over to the car and I see his son, Mac, with both his legs bandaged, an IV already in him. Apparently, they had taken him to the hospital where they told him that his injuries are too serious for them to be able to deal with and that they need to bring him to AUB. And he's, again, this amazing 10-year-old kid who is scared out of his brains. He's screaming that he's losing his legs and he can't feel them. And I'm supposed to help him out. I carry him, rush into the emergency room with him, his brother in tow. And I could feel pulses in his feet. I was immediately relieved. Doesn't sound like the injuries are that bad. So we take him into a proper space, undo the bandages, look at his injuries. They're pretty deep lacerations. There's some bone exposed on some of them. Looks like his quadriceps tendon is ruptured on one of his legs. Not fully ruptured, but maybe a 50% tear. This is something that needs to be fixed in the operating room. You can't fix it in the trauma room. And it's not a life-threatening or a limb-threatening or any serious threatening injury. He's a very good football player. Football is his life. If it doesn't get fixed, his football career is done, but it's not something that needs to be dealt with today. This is one of my good friend's son. So again, making a decision that, you know what, we're just going to bandage you. You're going to go home and you're going to come back tomorrow and we're going to take care of all of these injuries in the operating room tomorrow is something that at one point probably sounded crazy to his mother. And at the same time, she saw the chaos that was happening and was just very grateful to get out of the emergency room, knowing that we would take care of her son. So that was beyond us, luckily. Go back to the main trauma bay, and Dr. Halal is completely in control. He's orchestrating everyone. The residents are doing an amazing job. The residents all really just stepped up to the plate, did an amazing job. I remembered seeing a patient who was being wheeled in. He was pale as hell. He was talking, but looked like he had a major injury. And then I was told that Dr. Burji, one of the cardiothoracic surgeons, had taken him to the OR because they found that he was having a cardiac tamponade. Okay, uh, great. He's a qualified person to take care of that, right? And then I discussed with Dr. Halal that we need to start figuring out what happened to all the patients that we sort of treated and admitted and so forth. So I told him I was just going to round in the emergency room first, look at what's going on. And I passed by Violette's mom. If you remember, she is the older lady with multiple facial fractures and a subarachnoid hemorrhage. She's there with a medical student who is treating her really well, bandaging some of her injuries, but she's vomiting and she's sort of a bit delirious. She was completely with it before. All of a sudden, she's having signs of increased intracranial pressure. So I immediately grab one of the anesthesiologists, tell them to intubate her, and get her a bed in the ICU. And then, as I'm getting ready to finish rounding on other patients, one of the clerks from the operating room comes up to me and he goes, "We need a general surgeon right now in room 6 where Dr. Burji is operating." So I run down to room 6 and Dr. Burji is done with the chest, but he's done a laparotomy and there's blood all over. It's spurting all over and he's trying to get control and he's having a really hard time. So I scrub in and you can see the inferior vena cava through a liver that's completely split. It's just a shattered liver, bleeding like crazy. Again, take your own pulse. What do you do with major liver trauma? The first thing you need to do is stop the bleeding, start packing. So that comes back to me. I start packing the abdomen, just putting lap pads over and putting some pressure on the liver. And the packs are soaking through pretty quickly. So the next thing you need to do is a Pringle maneuver. I remember, fuck, I can't believe I remember what a Pringle maneuver is. So put my hands in there and do a Pringle maneuver. Suddenly the bleeding is controlled. It's still bleeding, but it's controlled. We can actually see what we're doing. And like I said, this liver is completely split in half. Um, I haven't done a proper liver operation in years, but luckily, you know, Dr. Faraj, our hepatobiliary surgeon, is here. So call him over, show him what we've got. We've got control. He takes over. There's no point for a cardiothoracic surgeon and 2 general surgeons to be in the same room, right? So I leave. Dr. Faraj and Dr. Buji finish up. But in the meantime, one of the residents grabs me and says, "We've got another patient with a liver injury who needs to go to the OR right now. His CT scan shows free intra and retroperitoneal air and a hemoperitoneum. We're rolling him down to OR4 right now." So I'm thinking retroperitoneal air, intraperitoneal air. This guy has some sort of duodenal injury and you know, probably if he's got a hemoperitoneum, he's got a major vascular injury. We get him into the operating room. He has a chest tube in place, already has about 500 cc's in his chest, out of his chest tube. We start prepping him, and the anesthesiologist looks at me and says, "You know that they have no more blood in the blood bank, right?" Well, I'm going to do a major trauma laparotomy on a patient with a hemiperitoneum without blood. That doesn't make sense. So I go back and look at the CT scan. The CT scan shows definite intraperitoneal and retroperitoneal air. There's a big hematoma around the right kidney. There's some blood in the abdomen, not too much, and there's a bit of blood around the spleen. So it sounds like the major injury really is probably a duodenal injury and not a major vascular injury. We can maybe wait to make sure we've got blood before we actually go into this laparotomy. And so I go back in the operating room, tell the anesthesiologist that I'm going to hold off on the laparotomy and find that he has an additional liter out of his chest tube. Now that takes priority. We need to basically look in his chest. So Dr. Burji is there. He does the thoracotomy. There's multiple rib fractures. There's a diaphragmatic injury. It's very posterior. He can feel the liver through the diaphragm. And you can feel some lacerations in the liver where the broken bones probably rubbed against the same thing. So he gets control in the chest, but the patient's becoming unstable again. So now there's no turning back. We need to do the laparotomy, even if there is no blood. But luckily, we have blood. So we do the laparotomy. He's got some liver lacerations that are relatively easy to control. The spleen looks okay. I cochlearized the duodenum. I think the residents were shocked when they heard me say cochlearized the duodenum because I was shocked saying it. I hadn't cochlearized the duodenum in 10 years. But again, take your own pulse. Remember your training. Remember what you've done in the past. So you don't need to be doing something every day for you to remember what you need to do. Duodenum looks intact. There's a major hematoma around the right kidney. We don't need to do anything about it. It's not expanding. So the diaphragm, the diaphragmatic tear is pretty posterior. We don't need to do anything about that because the liver is covering it. So we got control of his bleeding and came out. At this time, it's probably about 11 o'clock at night. I'm walking out of the operating room and people are asking me about their loved ones. And I'm like, I have no clue who I just operated. I don't know the name of the patient I operated on. I don't know the names of any of the patients who are in the operating room. What I might be able to recognize a picture if you show me one. And I go back into room 6 to check on how our patient's doing. We managed to get control of the liver bleeding. Dr. Feresh did an amazing job at controlling it and basically uh, stopping the major hemorrhage that the patient had from the liver. But the patient died. He had a major head trauma that went unrecognized because of his other injuries, which, of course, doesn't mean that anything was done wrong. Everything was done within proper trauma protocol. So you have tamponade, you treat that. You have major abdominal bleeding, you treat that, and then you realize that the patient died of his head injury. That was obviously a huge blow, but there's more to be done. So we go back to the emergency room. At this point, the emergency room looks like things are finally starting to calm down. It's almost midnight. I really have no clue what happened to my house, which is close to the epicenter of the blast. So I make a deal with Dr. Halal. He's going to go start rounding on the floors with the residents, start going through the injuries of the 67 patients that we admitted. And I keep saying that number, 67. That is actually a huge number. When you look at the history of major traumas and major disasters, very few, I don't think any hospitals have admitted that many mass casualty patients with serious trauma injuries from one incident as we have. September 11th, most patients died. Not many patients made it to the operating room, to the hospitals. During the 2006 wars, casualties were not, people could not even get to the casualties. They were not making it to the hospitals, definitely not to AUB. the 2007 Madrid bombing, the train bombings in Madrid, they admitted 35 patients that day. They had a huge bombings on the train system at the peak busiest hours in Madrid, and they only had to admit 35 patients. The London bus bombings, again, not many had to be admitted on to the same hospital. So this is, a huge number of patients that all of a sudden got admitted to our hospital, and we don't know the injuries. So Dr. Halal, the residents started making rounds. I went home, saw that the damage to my house was less than I expected. But what stays with me from going home was how I was completely numb. You're driving in Beirut, and I'm sure a lot of you experienced this. You're just driving on glass all over. It's a complete apocalyptic scene. And you get home and, I go into the garage of my building and everything's just completely fallen apart. There's ceiling and fixtures all over the place. Everything is completely covered in dust and damaged cars and so forth in the garage. Doors blown to pieces. I was stupid enough to take the elevator. I didn't even think about it. But the elevator was working. I took it. Luckily, it got me home. And, I assessed the damage at home, closed whatever I could in terms of the windows, and just collapsed on my children's bed because mine was covered in ashes and dust and all of that. Couldn't really get into my bed. And I collapsed on one of my children's bed and started going through messages. And I get messages from friends who are in panic because their loved ones are injured and so forth. And these messages are now 6 and 7 hours old, and I can't do much about it. But it's important that I try to get a couple of hours rest, because at 6:30 that morning I went straight back to the hospital and continued where Dr. Halal left off, which was rounding on all of the injuries and so forth. And I think the greatest moment of relief to me was when I saw that the 4-day-old girl who I had I'd prevented from going into the CT scan as a priority and prioritized another patient, turned out to have a negative CT scan, was doing great. She was basically in her mom's arms and she was feeding very comfortably when we saw her. Apologize to the father that I'd had to make that decision. That was the right decision to make, and he totally understood and went on to continue the rounds. I think, when I look back at what happened at AUB that day, it's a major tragedy and extremely traumatic experience for all of us. But I cannot but help and look back at it and take pride in what we did, because we managed to save a lot of patients. We managed to deal with a huge amount of chaos, but at some point got that under control. Obviously, there were some errors that were made. I know of one major error that was made where a lady got an esophageal intubation instead of her airway being intubated. She ended up dying, but I think she had severe enough injuries that no matter how well things were done, she was going to die anyway. But still, you always feel bad that things didn't go 100%. But like I said, when I think back at that day, it just reminds me of how all of my training and experiences set me up for being able to deal with this successfully. So, from the minute I saw that plume of smoke, and initial instinct was there won't be any communication. I need to get that off my shoulders, the message out, to thinking of our disaster plans and so forth. So I think one of the key messages I took from this is that you learn a lot during your training and your experience. It never goes away if you really just keep being systematic about it. So, we keep talking about the ABCs of trauma, for example, but that's how we manage to save people. And I think going back to those ABCs at any point and every point is what keeps you grounded and sane, to the point where you don't panic and you just sort of are systematic and go through everything. And that's what helps save lives. And that's how we got through August 4th.
So this was such a personal and touching reflection. I think we all really personal stories, so many lessons that we can all relate to. And you provided so much room for insight. So I'm pretty sure we're all very grateful for this session. Basically, the concept of applying the ABCs of trauma is one of the biggest lessons that we can take from this talk. It's a wonderful way of approaching things, and it's something I believe that's essential that we cannot only apply to surgery, but also to life in general. So I'd like to thank you again. We don't have any questions in the chat box for this particular session, but overall, we're very glad to have you in this session and sessions to come. So much.
It's a pleasure, Resha. I look forward to a little bit more of a formal session next time. But yeah, I thought it's good to share this with you guys.
Thank you, and we hope to see you all in the upcoming sessions. Have a great day, everybody.